Now, moving on to our last section, that is the carpal dislocation and subluxations. As I told you, the most commonly with the case of lunate is that it either there is a lunate dislocation or there is a perilunate dislocation. That lunate stays in its place, but all of the carpus itself dislocates. Then there could be a scapholunate dissociation or tricutal dissociation, in which there's mainly the ligamentous injuries, but they are highly pathognomonic for chronic instability of the wrist joint. So coming to the rheonate and peronate dislocations, if you see this x-ray, if you see it over here, as I told you, usually there is always the lunate on a normal x-ray appears quadrangular, but if you see closely, this is the partially the scaphoid is masked and there is a triangular appearance of the lunate. This is actually tells you there's something wrong over here on the AP view, and if you see it on the lateral view, you can appreciate the lunate is dislocated outside the carpal bones. So there is a term called as cup in the cup appearance. So this one cup is actually the distal radial part, then in which there is a lunate, and then there is actually this bone which is actually right over there. So cup in the cup appearance is actually distorted on the lateral view. When it happens when the fall with the hand is forced into the dorsiflexion, especially when in case of the fall in the outstretched hand. And this may tear the tough ligaments, especially the scapholunate ligament, trochanter ligaments may be damaged. Sometimes when it's a lunate dislocation, the lunate remains attached to the radius and whole of the corpus actually dislocates. This is termed as perilunate dislocation. But if only the lunate dislocates, it is called as lunate dislocation as well. Now there is another term called as transscaphoid perilunate dislocation. Now this happens when there is a perilunate dislocation associated with the scaphoid fracture. That is when you call it a transscaphoid perilunate dislocation. And what are the clinical features? The most common is always the wrist pain, which is acute injury, and there is a swollen, massive swelling around the wrist joint. It's very painful, and usually you cannot move the hand. The wrist is actually held immobile. If the carpal tunnel is compressed, this is maybe resulting in edema and hematoma over there and swelling over there. This may result in partial compression of the carpal tunnel. There may be paresthesias over the palm and especially over the volar aspect of the palm. Then there may be blunting sensation in the tertiary territory of the median nerve, which is actually supplied over the thenar eminence as well as the radial 3.5 fingers. And then there is a weakness of palmar abduction of the thumb because the muscles which are supplied by the thenar eminence is actually mainly through the median nerve. On X-rays, now this is the AP view. You can appreciate there is a scaphoid fracture with probably dislocation of the lunate. And if you see on the lateral view, this is the distal radius, there's one cup, so lunate is right here, but whole of the other carpals actually have dislocated. So this is where you call it transscaphoid perilunate dislocation. So you have to, on the AP view, you have to look for the carpus diminish in height. The bone shadows may overlap abnormally. One or more carpal bones may be fractured, especially the scaphoid. Usually the scaphoid or the radial styloid is fractured, and most dislocation are perilunate. The lunate stays in its place, but the whole of the other carpal bones are actually dislocated over the lunate. If the lunate is dislocated, if you see it over here, there is a carpal bone fracture, which is called scaphoid. This is a triangular appearance of the lunate, which actually shows probably there is a dislocation as well. And then if you see on the lateral view, there is subluxed or dislocated lunate as well. That has a characteristic triangular shape. Normally on an AP view, the lunate would appear quadrangular. But if it appears in triangular, this means most likely the lunate is dislocated. As I told you, instead of normal, quadrilateral appearance. On the lateral view, it's easy to distinguish lunate from perilunate dislocation because in the perilunate dislocation, the lunate stays in the radius groove. That is a radiolunate fossa, while the other carpal bones seems to be dislocated or out of sort of the radial styloid. But in the lunate dislocation, other carpal bones are over in the same place, but the lunate actually pops out of the radiolunate fossa. On X-ray, now again, if you see on this X-ray, this looks normal. At least there is a quadrilateral type of a lunate, and scaphoid looks normal, but there may be associated subtle fractures which we are not sure about. Usually on X-rays that will show a dislocated lunate which tilts forward and displaced in front of the radius. Now this can go volarly or dorsally, and that is where capitated or metacarpal bones are also lie within the radius. But in case of a perineal dislocation, the lunate is tilted only slightly, while lunate is not displaced, but whole of the other capitated metacarpals actually are usually displaced dorsally and causing a dorsal intercalated segmental instability. If associated with scaphoid fracture, it is called as transscaphoid perineal dislocation. Now coming to the treatment. Now the first and foremost is always of any dislocation is to reduce it closely. Under the GA, first the surgeon pulls strongly on the dorsiflexed hand. If the hand is held in dorsiflexion, a lot of pull has been done. That is the procedure. Then slowly it flexes the wrist joint. When the surgeon is flexing the wrist joint, is actually applying the pressure on the lunate to push it back into the radiolunate fossa. At the same time, squeezing the lunate backwards with the other thumb. This maneuver usually affects reduction and converts conversion of perilunate to lunate dislocation. At least you ensure now that what other bones have actually reduced back, only one bone is left which needs reduction. Plaster spread is applied holding with the wrist in the neutral position. And if we are able to reduce it closely, then we can apply for the plaster spread. But if it is not reduced by closed maneuvers, then probably open reduction internal fixation along with the reduction of the perineal dislocation is always required. And when we are fixing these bones, we usually require percutaneous K-wires can be done to hold the reduction in place. And if it is associated with scaphoid fracture, we probably would require a percutaneous screw fixation as well. If we have failed the closed attempt, a closed reduction fails, then we have to go for open reduction. That the carpus is exposed by anterior or dorsal approach. But now there is a catch over here. Some books say if it is volarly displaced perineal dislocation, then you open it through the volar side. But most commonly, it is always the dorsally displaced fracture, so it is opened through the dorsal or anterior approach. Assistant pulls on the hand and lunate is levered into plates and kept there by K-wire. The K-wire inserted through the lunate is into the capitate, so that you are inserting now, you are restoring the lunocapitate joint first. Then the torn ligaments, especially the scapholunate and lunocapital ligaments, are repaired, and wrist is actually splintered in the neutral position for 6 weeks. Now it's important over here that you repair the ligaments as well. Otherwise, later on, this is going to be resulting in instability at the wrist joint and general arthritis and pain of the wrist joint with mobility. And wrist is always splintered in a plaster cast, which is retained for usually 6 weeks. Minimum are usually 6 to 8 weeks. It can be kept there as well. Now coming to the scapholunate dislocation. Now scapholunate dissociation is important because there is actually scapholunate ligamentous injury as well. If you see, this is the scaphoid. Can you appreciate how much gap is there in the lunate? Although it appears quadrilateral, this means there is no lunate dislocation or pelvic dislocation. Scaphoid looks okay, but there's probably either there's a fracture, but dorsal tubercle appears slightly tilted, and but if you see the gap, there is a lot of gap between the scaphoid and lunate, which is normally less than 3 mm. So that is where, when you are looking at the X-ray, you not have to look at the bones as well. You have to look at the gaps between the bones as well, or subluxation of the bones relative to each other as well. That is which tells you telltale signs whether their associated ligamentous injury is present or not. Usually clinical features is most common due to the fall on the outstretched hand is with usually either it's the wrist is ulnarly or radially deviated, there's pain and swelling, there's tenderness over the dorsum, and the push backwards on the scaphoid tubercle is painful. If you are examining the scaphoid tubercle with volarly push it towards the dorsal side, it's highly painful. Watson test is positive. This means the scapholunate ligamentous injury is there is a instability, especially the scapholunate instability is present. This is maybe significant instability here with a large gap between the scaphoid and lunate and typical of cortical ring sign is seen which is why, because there is a dorsal tubercle over the dorsal pole of the scaphoid. Due to the rotation of the scaphoid, this pole appears in the normal view and it appears like a cortical ring sign as well. And in the lateral view, there is actually dorsal intercalated segmental instability. If you see it on the lateral view, you can appreciate that probably leonate and other carpal bones are dorsally subluxed or dislocated and producing an instability pattern over the dorsal surface. In children, if this is suspected radiographically, usually competent clinical examination needs assurance, because sometimes the scaphoids are not developed. There is normally a more than one gap is there. Our leonate may be having a very small ossific center and we may look abnormal. But the best way in children is to get an X-ray of the opposite wrist as well. That will probably ensure whether this scapholionate gap is more than the other side or it's as much as equal to the other side as well or not. Injury, although is extremely rare, and you need a very critical eye to be on the for this, and usually it's misdiagnosed due to asymmetric ossifications. That is why it's seen in the scaphoid particularly. The best way is to just get a CT scan. If you cannot get a CT scan, the best is to get an MRI to look for subtle ligamentous injuries which may not be picked up clinically or which may not be very easily visible on the X-ray as well. Treatment of acute injuries. If there is acute scapholionate ligamentous dissociation, that is usually with repairing of interosseous suture. And how we do it, as it is associated dorsal intercalated segmental instability. So the dorsal approach is used around the wrist joint. We go in through the dorsally, repair these ligaments, and keep it protect these bones with K wires for 6 weeks and apply a splint. And cast is usually done for 8 to 12 weeks at times as well, but minimum it is 6 weeks is required. Then ligamentous reconstruction may be attempted, but if it's a chronic instability, that ligaments have been torn quite a long time and now the patient is actually complaining of chronic instability, then there is actually grading. There is grade 1, 2, 3 and 4. Depending on what type of the grade injuries, different options are available. This could be simply arthroscopic reconstruction of the chronic injury to the tendon, to the ligament, or there could be other highly advanced options as well. If there's advanced arthritis, this could be in form of proximal row carpectomy, or it could be arthrodesis. Or if it's stage 2 or 3, then probably we can go for a 4-corner fusion, which is actually joining the scapholionate as well as the lienocapitate ligament, and scaphocapitate are joined in such a way that it becomes a 4-corner fusion for the stability of scapholionate dissociation. But then again, when we are discussing the scapholionate dissociation, it's not only depends upon whether it's acute or chronic, what is the grade of the injury, as well as what is the clinical parameters which exist for the patient, and what is the patient's expectation as well. All these actually are the things which are dictate the treatment of the scapholionate dissociation. Now coming to another important term, which is called a lienotriquetral dissociation, or VC. Why it's called as VC? Because it's called as volar intercalated segmental instability. Although it's rare relative to the DC, but it's due to the fall on the ulnar side of the hand, in which there's fall on the outstretched hand with ulnar deviatedly wrist joint. Usually ulnar carpal pain associated with weakness of grip, and there is tendon distal to the head of the ulna. If you see it over here, you can appreciate probably there is some degree of the gap between the leonate and triquetral, and that is why, because there is a ligamentous dissociation of the lienotriquetral ligament, and disruption occurs at the lienotriquetral ligaments level. On X-ray, there will be an AP view, and on the lateral views you can appreciate physical and X-ray signs as well, which may be subtle. X-ray may sometimes show gap or step between the triquetrium and leonate, which may be no more than 3 mm. Or VC, volar intercalated segmental instability. When you look at the X-ray on the lateral side, you can appreciate the carpal being subluxed volarly. The treatment of acute is very simple. If there is acute tears, you go for repaired by interosseous sutures and supported by temporary K wires. The lienotriquetral K wires are placed for 6 weeks, and casting can be done for 8 to 12 weeks as with the scapholionate ligamentous injury in case of acute. But the problem starts when there is a chronic injury. In chronic injuries, the ligament substitution can be done, especially the slip of extensor carpi ulnaris can be substituted for the lienotriacetal ligament. Although limited intercarpal fusion may be considered if lienotriacetal arthritis has developed beyond a certain stage, this may lead to fusion or arthrodesis of this level, so that later on the pain which can be settled, especially when advanced arthritis of the lienotriacetal joint is present. In this section, we have briefly gone through the two important entities. First, the lunate and the perilunar dislocation, as well as along with the transscaphoid perilunar dislocation. Usually, lunate appears to be a quadrilateral on AP, and on the lateral view, it appears to be a cup in the cup appearance. But if it's a lunate dislocation, lunate would pop out of the radiolunate gap, which can be appreciated on the lateral view, and on AP view, it would appear triangular. If it's a perilunar dislocation, this is the lunate stays in its place, but the whole of the other carpal bones actually dissociate more commonly towards the dorsal side. Then that is why it is called as perilunar dislocation. When it is associated with the carpal bone fractures, and most commonly it is always with the scaphoid, it is called as transscaphoid perilunar dislocation. The treatment to any dislocation is simple. The first and foremost is closed reduction under GA. If it fails, we have to go for open reduction, internal fixation with K-wires, and post-operatively splint can be given for 8 to 12 weeks. Now, the other two entities we discussed in this section was the scapholunate dissociation, or the DC, that is the dorsal intercalated segment instability, and lienotriacetal dissociation, or the VC, volar intercalated segmental instability. In acute stage, both are repaired by intraosseous sutures. K-wires can be placed for 6 weeks, and splint can be given for 8 to 12 weeks. But in chronic, and then it depends what is the grade of the basically the tears and what are the different options. These options could be simply four corner fusion, this could be proximal row carpectomy, or this could be simply the proximal row arthrodesis, especially in the case of the DC. While in case of lienotriacetal arthritis, this could be simply lienotriacetal fusion, which could be done if it's the advanced case. Thank you very much. Keep watching sqadia.com.